Each time you give a drug or medication to a patient, you are faced with making decisions about the drug effects, patient's health, and safety. As a nurse, your decisions about drug administration can have legal or ethical consequences. For example, in assisted living or nursing home facilities, it is a common practice to mix drugs with food or drink, mainly to help patients swallow their prescribed drugs more easily. Before you decide to give drugs mixed in food or drink, there are several things you should consider. You have an ethical responsibility to inform the patient's care provider, the patient, and the family that you will be giving the drugs in this manner. Failure to inform the provider, patient, or family of this practice is considered covert drug administration, which, although not illegal, is not considered a best practice in drug administration. The mixing of drugs in food or drink must be documented in the patient's care plan on the drug administration chart to address the legal aspects of this practice. Certain foods or drinks, such as grapefruit juice, should not be taken with certain drugs because this practice may influence the effect of the drug. It is important to check your drug handbook before mixing drugs with any food or liquid. Another common practice for easing drug administration is crushing pills or opening the capsules. It is important to know which types of drugs cannot be crushed or have the capsules opened. For example, a 325 milligram enteric-coated aspirin pill may be difficult for some patients to swallow, but crushing the drug affects the speed at which it is absorbed and increases the chance that the patient will develop a stomach ulcer. Some drugs have a coating that slows the release of the drug. Crushing the capsules and tablets releases all of the drug at once, instead of slowly over time, and can result in accidental overdose. The Institute for Safe Medical Practice has published a Do Not Crush list that can be used for reference and is posted on their website, ismp.org/tools/do-not-crush.pdf. An important legal and ethical issue facing nurses is known as the drug diversion. Drug diversion is defined as the illegal transfer of regulated drugs, such as narcotics, from the patient for whom they were prescribed to another person, a nurse, for use by themselves or others. When a nurse diverts a prescribed drug, it can result in significant threats to patient safety, and it is a liability for the healthcare organization that employs the nurse. The American Nurse Association has defined an impaired nurse as one who cannot meet the professional code of ethics because of excessive use of alcohol or drugs. When drug diversion is suspected, the organization is required to launch a full-scale investigation. The nurse involved will most likely face disciplinary charges that will include treatment, resources for the nurse with drug or alcohol addiction, and may include suspension or permanent loss of the nurse's license. Nurse leaders have a legal and ethical obligation to protect against patients and the profession from impaired nurses. Some behaviors that may signal a drug or alcohol dependency problem in a nurse include increased absences, lateness to work, unexplained disappearance from the assigned unit, decreased alertness, Drug diversion should also be suspected if patients continuously report pain despite appropriate drug treatment, and if inaccurate narcotic counts are also noted. Chapter 2, Legal, Regulatory, and Ethical Aspects of Drug Administration. Regulation of drug administration. Nurses who give drugs are required to follow 3 levels of rules. 1. Federal laws, which describe rules that control how certain drugs may be given. 2. State laws and regulations or rules which specify who may prescribe, dispense, give a supply, or give drugs, and the process to be used. 3. Individual hospital or agency rules, which may specify other guidelines or policies regarding how and when drugs are given and the records that must be kept recording drug treatment. Federal laws. Laws are passed by Congress to make drugs as safe as possible for patients to take and to ensure that the drug does what it claims to do. The effectiveness. Congress created the U.S. Food and Drug Administration, known as the FDA, to monitor or watch over the testing, approval, and marketing of new drugs. These regulations are very strict, and U.S. drugs are some of the purest and most protected drugs in the world. Many laws have been passed to control drugs that might easily be abused and are dangerous. These laws define the 3 drug categories in the United States. Number 1, controlled substances, which include opioids, narcotics, and some sedatives or tranquilizers. Number 2, prescription drugs such as antibiotics and oral contraceptives. And number 3, over-the-counter, also known as OTC, drugs that are available without a prescription. Controlled substances. Most regulations are written for controlled substances because they are most often abused by patients and general public. The Controlled Substance Act of 1970 classified these drugs into 5 schedules, and they became known as scheduled drugs. Each schedule rates the likelihood that the drugs in each category will be abused, causing dependency or addiction. For example, Schedule 1 drugs such as heroin have no medical use and are considered highly addictive. Schedule 5 drugs such as cough medicine with low dose of codeine have a low potential for abuse. The degree of control, the record keeping required, the order forms, the other regulations are different for each of these 5 classes. There's a table in your book that describes the 5 drug schedules with examples of drugs in each of these categories. The drugs are sometimes moved from one class to another if it becomes clear they are being abused. Many states have approved the medical use of marijuana for the treatment of certain conditions, mostly in classes of terminal illnesses. Federal and state laws make it a crime for anyone to have controlled substances without a prescription. Each state has a practice act that lists which healthcare providers may dispense or write prescriptions for controlled substances. Almost all states have programs for prescription monitoring of controlled substances received by patients from several different providers to prevent prescription drug abuse. Physicians, dentists, nurse practitioners, physician's assistants, and sometimes nurse midwives may write prescriptions for controlled substances. Pharmacists dispense the drugs according to the provider's orders. Licensed practical nurses, LPNs, or licensed vocational nurses, LVNs, may give controlled substances to a patient only if the State Board of Nursing permits it in their scope of practice, and they must be under the direction of a healthcare provider who is licensed to prescribe these drugs. LPN VNs work in many different settings. Some settings have high levels of technology for securing controlled substances, and others may have or use double lock systems. Each state and healthcare agency has laws and policies that cover ordering, receiving, storing, and record keeping of controlled substances. Opioids, narcotics, are scheduled drugs, and they must be counted every shift. Records must be kept for every dose given. Agency policy determines which nurses will be held responsible for handling over the control of controlled substances from one shift to the next, and for counting and securing of controlled substances. All controlled substances that are ordered for a patient but not used during the hospital stay are sent back to the pharmacy when the patient is discharged. Nurses may not borrow a drug ordered for one patient to use for another patient, and they may not never use the drugs for themselves. In a time when drug abuse is so common, the nurse who has responsibility for the controlled substances must remain alert. About 8% to 15% of healthcare professionals have a history of substance abuse, and there is a risk for drug diversion. A pattern of drugs frequently being dropped or spilled, or records that show a patient received large or more frequent doses of drugs without pain relief can serve as clues to possible drug diversion. As a nurse, you must know the federal, state, and agency rules about giving any type of drug, including controlled substances. The rules that govern controlled substances are very clear and very strict. If you violate the controlled substance laws, you may be punished by a fine, a prison sentence, or both. Nurses with proven drug abuse problems lose their license to practice, at least temporarily, and may have a hard time getting it back. Nurses have an ethical and a legal responsibility to report suspected drug diversion. In most states, the State Board of Nursing has a program to help nurses with substance abuse that affects their ability to carry out their nursing duties. At the end of each shift, the responsibility for all controlled substances and the key to the controlled substances cabinet are transferred to another authorized nurse from the new shift. Keys or electronic access to controlled substances are never given to the physicians or any other unauthorized healthcare worker. The contents of the locked cabinet are counted together by one nurse from each shift. The numbers of each ampule, tablet, and pre-filled syringe in the cabinet must match the numbers listed in the inventory report form. Sealed packages are kept sealed. Open drug packages must be inspected and counted. Pre-filled syringes must be examined to make sure that they have the same color, the same fluid levels, and the same amounts of air within them. Both nurses must sign the inventory report officially stating that the records and inventory are accurate at the time. Occasionally, the inventory and the written report do not agree. Any disagreement between the number of remaining doses and the number listed in the inventory report must be explained. All nurses who have access to the key must be asked about drugs they have given. Steps must be retraced to see if anyone or if someone forgot to record any drug. Patient charts can also be checked to see if a drug was given that was not signed for on the inventory report. If errors in the report cannot be found, both the pharmacy and the nursing service office must be notified, and an investigation is open to determine if drug diversion has occurred. Depending on the type of magnitude of the issue, the institution or agency administrator and security police also may be contacted. A memory jogger about physical dependence refers to the physical symptoms occurring during drug withdrawal. Symptoms such as shaking, increased heart rate, pain, confusion, seizures, or other troubling symptoms could occur. Physiological dependence or addiction is a mental desire associated with taking certain substances, such as cocaine or alcohol. Symptoms of mental dependence, such as anxiety, anger, or depression, can occur with psychological dependence. The classification of controlled substances here in the United States, the schedules that are listed here are from 1 through 5, and it talks about the potential of abuse. And then it gives examples of medications or the examples of the drugs. The examples that are going to be mentioned are the ones that are commonly known. There are going to be some drugs and some medications that are not going to be mentioned, and those are the ones that we are not going to concentrate on. So, Schedule 1 are high potential for abuse. They're not accepted medical use in treatment in the United States. They lack an acceptance of safety for use of drug or other substance under medical supervision. More than 80 drugs or substances of which the following are best known: heroin, LSD, marijuana is also listed in this category. Schedule 2, high potential for abuse. Currently accepted use for treatment in the United States. Abuse may lead to severe psychological dependence or physical dependence. More than 30 drugs or substances of which the following are best known: fentanyl, hydromorphone, dilaudid, meperidine, Demerol, morphine, oxycodone, Schedule 3, potential for abuse less than the drugs or substances in Schedules 1 and 2. Currently accepted medical use for treatment in the United States. Abuse may lead to moderate or low physical dependence or high psychological dependence. Most drugs or compounds containing some small amounts of the drugs from Schedule 2, along with acetaminophen or aspirin, such as Tylenol with codeine, number 3, or number 4, and Furanol. With other drugs include anabolic steroids such as testosterone preparations and sodium oxybate, Xerum, a drug that contains GHB for use with the sleep disorder narcolepsy. Schedule 4. Low potential for abuse relative to the drugs or substances in Schedule 3. Currently accepted medical use for treatment in the United States. Abuse may lead to limited physical dependence or physiological dependence relative to the drugs or substances in Schedule 3. Includes diet drugs containing propionic acid. Other well-known drugs include benzodiazepines such as lorazepam, known as Ativan, flurazepam, known as Dalamine, diazepam, known as Valium, midazolam, known as Versed, and alprazolam, known as Xanax. Schedule 5. Low potential for abuse relative to the drugs or substance in Schedule 4. Currently accepted medical use in the United States. Abuse may lead to limited physical dependence or psychological dependence relative to the drugs or substances in Schedule 4. Includes cough preparations containing small amounts of codeine and drugs for diarrhea that contain small amounts of opioids, such as diphenoxylate with atropine, known as Lomotil. Prescription drugs in the United States. The safety and effectiveness of prescription drugs are regulated by the Federal Prescription Drug Marketing Act of 1987, and it is the responsibility of the Food and Drug Administration, the FDA, to decide which drugs will require a prescription to be obtained. This regulation is in place to prevent prescription drug misuse and abuse. The ability to write prescriptions is provided to only a few healthcare professionals, physicians, dentists, nurse practitioners, and physician's assistants. Misuse or abuse of prescription drugs can lead to adverse drug events, including those caused by dangerous drug interactions. The most commonly abused prescription drugs include narcotics, opioids, and drugs given for sleep or anxiety disorders. The Omnibus Budget Reconciliation Acts of 1989, 1990, and 1991 placed further controls on the drugs for Medicare and older adult patients. According to one study, as many as 15% of older adults are at risk for potential major drug-to-drug interactions. Older patients are at high risk for problems with prescription drugs. They may not take the drug properly because of poor eyesight, memory, or coordination. They may take many drugs that interact with each other, or they may have chronic diseases that interfere with how the drugs work. Medicare Plan D provides coverage of some types of drugs for those who pay for this option. More and more insurance and government groups that pay for drugs limit the types and numbers of drugs that may be ordered to those on a preferred drug list. The preferred drug list may require the use of cheaper generic drugs to control cost because new or brand name drugs usually are more expensive. Many drugs are not FDA approved as safe and effective for children or pregnant women. Prescription drugs make up most of the drugs given to patients in assisted living centers, nursing homes, or hospitals. Prescription drugs are carefully tested for safety and effectiveness before they are put on the market. However, even though much may be known about a particular drug, each patient can have different reactions to it. You must know the expected and adverse effects of drugs given to your patients and watch for signs that the drug is working the way that it should. Any adverse reaction that may develop must be reported to the ordering provider. Patients often get several drugs at the same time, and the interaction among the drugs may make it hard to tell how each drug affects the patient, making your nursing knowledge of these drugs a critical part of the safe nursing practice. The FDA has also found that many drugs are safe enough not to need a prescription. These drugs are known as over-the-counter drugs. They are used to treat many common, minor problems such as colds, allergies, headaches, minor burns, constipation, or upset stomach. These drugs may easily be purchased at a drugstore or pharmacy. They are often the first thing patients try before they go to the doctor. Although over-the-counter drugs are widely available, they are not without some risk. Like all drugs, some over-the-counter drugs may produce adverse effects in some patients. There is also the possibility of drug or food interactions or harm caused by excessive doses. Patients should be taught to read the drug facts label that is included in all over-the-counter products and to consult with their pharmacist or other healthcare provider if they have additional questions concerning over-the-counter drug use. Accidental overdoses of common cold drugs in children have occurred because of confusion by parents about the correct dosage to give, and these drugs are no longer recommended for use in pediatric patients. Studies have shown that 40% of parents give their children incorrect dosages of liquid drugs. Cold and allergy products that contain pseudoephedrine and can be used to make illegal drugs are now stored behind the pharmacy counter and are sold in limited quantities. Over-the-counter drugs that are given in assisted living centers, nursing homes, and hospitals require a legal prescriber's order before they are given. Without an order in these settings, patients cannot take even their own over-the-counter drugs brought with them. Both state law and agency policy require that all drugs given in hospital and long-term care facilities must be ordered by licensed healthcare providers, acting within their scope of practice. This generally restricts prospective authority, the authority to write an order or prescription for drugs, to physicians, dentists, nurse practitioners, nurse midwives, nurse anesthetists, and physician assistants. Providers who write the prescriptions are also called prescribers. Prescriptions for a hospitalized patient are written in the specified area of a patient's chart or recorded in the electronic record, and the pharmacy is notified. In some agencies, the order must be transcribed or rewritten by an authorized individual onto the special pharmacy order form, which is then sent to the pharmacy. Assisted living facilities and long-term care facilities may have providers who evaluate the patients and order or issue reoccurring orders for patient drugs. Every time a patient has a prescription filled, the pharmacy is required to give information about the drug and how it is to be given. A legal prescription order must contain the patient's full name, date, the name of the drug, the route of administration, dose, frequency, duration, signature of prescriber. Additional details about how to give the drug may also be written. For example, take with meals. Avoid milk products with this drug. Do not refill. May cause drowsiness. Or, please label. Pharmacies also require the patient's age and address on the prescription. This information may help the pharmacist ensure the right drug dosage for the patient, child, older adult, and verify the patient's identity. In emergencies, or if the provider is not available on site, a verbal order, usually over the telephone, may be given. All agencies that employ nurses have policies about verbal orders. The agency decides who is authorized to take, transcribe, and implement verbal orders. The nurse taking the order is responsible for writing the order on the order form, in the medical record, including the name of the nurse and the name of the prescriber. Many institutions also require that a note be written to indicate that the order was read back to the prescriber for validation. The prescriber must then co-sign the order, usually within 24 hours, for it to be valid. The receiving and transcribing of verbal telephone orders must be or may be the responsibility of the registered nurse, the RN. If it's your responsibility as an LPN or VN to be very familiar with the verbal order policy of the institution where you are practicing. Drug orders are classified into one of 4 types of standing order: the emergency order or STAT order, the single order, and the as needed or PRN order. The standing drug order indicates that the drug is to be given until discontinued or for a certain number of doses. Hospital or institution policy usually dictates that most standing orders expire after a certain number of days. A renewal order must then be written by the prescriber before the drug may be continued. Examples would be amoxicillin 500 milligrams orally every 8 hours for 10 days, ibuprofen 600 milligrams orally every 6 hours. An emergency or STAT drug order is a one-time order to be given immediately. An example is diphenhydramine 50 milligrams IV stat. A single drug order is a one-time order to be given at specified time. An example is cefazolin 1 gram IV at 10 a.m. before surgery. An as-needed or PRN drug order is an order for a drug to be given as needed, based on a nurse's judgment of safety and a patient need. An example is Ducasate, 100 milligrams orally at bedtime, as needed for constipation. State law and healthcare agency policies, although many regulations about giving drugs come from federal laws, details about who may prescribe and who may give drugs are set by each individual state. This authority is spelled out for nurses in the Nurse Practice Act of each state and can be found at the National Council of State Board of Nursing website. The National Council of State Board of Nursing can be located at www.ncsbn.org/npa.htm. Differences in practice from state to state make it essential that nurses learn what is legal regarding drug administration and make sure that they abide by the state rules and regulations. Because nurses may move from state to state, they must know exactly what is in the Nurses Practice Act of each state where they are licensed to work. Nurses often move between jobs, and some states recognize the nursing license of another state through an agreement called the Nurse Licensure Compact. There is a growing list of states that participate in the compact available at www.ncsbn.org. State rules about nursing practice often list the basic or minimum standards of practice. Agency or institutional policies and guidelines may be more specific or more restrictive than state nurse practice acts. Agencies that employ nurses must provide written policy statements about the educational preparation for nurses permitted to give drugs and an orientation to particular policies, procedures, and record-keeping rules of the agency. When you accept a nursing job, it is implied that you are willing to obey the policies or procedures of that institution. It may be an agency policy to require employment for a certain period, completion of special orientation and training sessions, and passage of a probation period before a nurse is permitted to give drugs. Even when you have the legal authority to give drugs, a valid drug order signed by an authorized prescriber is needed. Giving drugs is a responsibility reserved for nurses who are named by law to give drugs, who can document the appropriate educational preparation to do so. Nurses who give drugs to patients accept professional responsibility for giving drugs correctly, ethically, and legally. This means nurses must accept ethical and legal responsibility for good judgment and actions in drug administration and monitoring the effects of drugs given. Agencies accept nurses to carry out the steps of the nursing process, and you are responsible for good assessment planning, implementation, and evaluation of the patient when drugs are given. You will be held responsible for failure to perform any of these steps well. The nursing process is a helpful system to be used when giving drugs. There is a professional requirement and an implied ethical and legal requirement that nurses use this process. You must learn information about the patient's medical diagnosis, medical history, current symptoms, allergies, and current drugs taken. You are responsible for learning about all of the patient's prescribed drugs, the dosage, the route of administration, the expected response, the adverse reactions, and the monitoring that may be needed to ensure the drug is working as it should and to observe for drug interactions. You are responsible for the following all laws and agency policies that are related to giving the drugs, including the 9 rights of drug administration. You also teach the patient and the family the information they need to know for continued and safe administration of the drug. The drug administration system's one critical nursing responsibility is to check that the drug orders for your patient are correct. You may need to confirm the order you have using a drug cardex or other paper drug system, or using the electronic medical record, EMR, in a computerized system against the original order by the provider. Every agency has its own drug order, distribution, and recording system for the patient's health record. Agency policy will tell you what information is to be placed in each section. After you give the drug or drugs ordered, you must record all required drug administration information. Integrated within the EMR, Many facilities now use a bar-coded drug administration system to allow drug orders to be sent to the pharmacy when they are written. The drugs are sent to the patient's room or floor, and the drug is taken to the patient's bedside. The patient's bar-coded wristband and the barcode on each drug are scanned by the nurse using a handheld device. This ensures that the right patient is getting the right drug as noted in the drug order. As the patient is observed taking the drug, the nurse notes that the drug has been given and the chart is electronically updated with this information. An EMR and an integrated barcoded drug system have been several advantages. The use of a computer to create the record prevents illegible clinical handwriting, a common cause of drug errors. These systems also avoid having orders transcribed several times as they are sent to the pharmacy, given to the nurse, and so on. This results in fewer errors. Many systems are designed to indicate whether the dose ordered by the clinician is out of the acceptable dosage range or would interact with another ordered drug, whether there are other dosing errors, or if the patient has a recorded allergy to a prescribed drug. Another type of drug delivery system is known as a Pyxis, a BD Pyxis med station. The Pyxis is an automated drug dispensing system that provides computer-controlled storage, dispensing, and tracking of prescribed drugs. These automated systems are thought to improve efficiency in giving drugs while ensuring patient safety. The Cardex is a pen and paper flip file card system that has been used for many years. It contains important patient information and the physician's orders. It is regularly updated and changed to reflect current orders. This format keeps important information about the patient easily available for all team members. When a unit dose system is used, all drugs are listed in the Cardex or drug profile sheet. Drug errors. Drug or medication errors are costly to patients who suffer adverse effects or even death as a result. Organizations pay a financial price for drug errors that occur. Every drug error that is prevented saves the agency approximately $7,000. Drug errors can occur at any of the 3 points of the drug administration process. 1. During drug preparation. 2. Bringing the drug to the patient. And 3. Giving the drug to the patient. Studies have pointed to the fast pace of current clinical practice, lower staffing levels, multitasking, and interruptions during the process of preparing and giving drugs as potential causes of drug errors. Efforts to minimize interruptions during all 3 points of drug administration can reduce errors. Did you know that the 3 most common points where drug errors are made are during the drug preparation, bringing the drug to the patient, and giving the drug to the patient? Each agency has its policy and procedures that cover what to do when a drug error is made. Treating the drug errors with blame and fear may lead to fewer nurses reporting errors when they do occur. Nurses have an ethical responsibility to report drug errors because of possible harm to the patient, regardless of whether the nurse thinks the error may result in harm to the patient. All errors must be reported. If you suspect an error was made, immediately check the patient, notify the healthcare provider promptly, and follow any orders the provider gives to reduce the effect of the drug error. It is critical to watch the patient's condition by measuring vital signs, drawing blood for test, or using any other method ordered by the provider. Also notify the nursing supervisor and fill out any other agency required reports. After the reports are made, an investigation into how and why the error occurred will occur. The investigation will include how similar errors might have avoided in the future and how will consider any training of the nursing staff that might be needed. Consequences of drug errors may vary and are often related to how severe the error was and whether the patient was harmed. If the nurse was careless or negligent, she or he may be held professionally and or legally liable. Although almost every nurse has made one drug error, repeated errors will not be ignored. Research in each institution helps determine whether the mistakes made in that institution are most commonly caused by a system error or a unique mistake, failure to follow the 9 rights of drug administration, or deliberate wrongdoing. In 2000, the Institute of Medicine, IOM, published a very important report entitled "To Err is Human," about the number of errors made in medical care. Estimates suggest that the adverse events, which include medical errors, occur in 3% to 4% of patients. The IOM report and other studies have calculated that the cost of medical errors in the United States, and including lost income, disability, and need for additional health care, may be between $17 billion and $136.8 billion or more annually. These costs come from a variety of drug-related problems, including patient compliance issues and medical or drug errors. Unfortunately, estimates suggest that more than half of the adverse medical events each year are caused by medical errors that could be prevented. In response to this report, most agencies have tightened ways to report and follow up on drug errors, and some improvement has been confirmed in the most recent studies. Nurses must make every effort to follow agency policies and to work to minimize interruptions in order to prevent errors. An independent non-for-profit organization, the Joint Commission, known as TJC, accredits and certifies almost 21,000 healthcare organizations and programs in the United States. TJC accreditation and certification is recognized nationwide as a symbol of quality that reflects an organization's commitment to meeting certain performance standards. To cut down on drug errors, TJC has discouraged healthcare workers from using any abbreviations that might lead to confusion. Certain abbreviations that were used in the past, such as HS for nighttime, CC for cubic centimeter, QD for daily, and QOD for every other day, are no longer used in the hospitals that wish to maintain their accreditation. There's a table located in your chapter that lists TJC's official do not use abbreviations. A small category of drugs has a high risk of harm when associated with a drug error. They are called high alert drugs because the consequences of the errors are very serious. A high alert drug can cause harm to the patient who receives it in error, was not prescribed to receive it, and to those who receive too high a dose, receive too low a dose, or do not actually receive a prescribed dose. High alert drugs are often packaged, stored, and given differently than others. Some agencies require extra steps in the drug procedures before high alert drugs are given. Categories are common. High alert drugs can be remembered using an acronym PINCH, P-I-N-C-H. P is for potassium, I is for insulin, N is for narcotics, opioids, C is for cancer, chemotherapy drugs, and H is for heparin or any drug type that interferes with blood clotting. Information about high alert drugs in hospitals, community, and long-term care settings can be found online at www.ismp.org/recommendations. An additional way that some drugs are characterized is by their ability to harm the person taking them. Some drugs are assigned a black box warning by the FDA. This means that the drug has a higher than normal risk for causing serious and even life-threatening problems, in addition to its positive benefits for some people. A black bordered box is found on the drug insert and may be included on the patient instruction sheet provided by some pharmacies. There is an example of a black box warning. Prescribers must take extra care in deciding whether to prescribe a drug that has a black box warning. The patient is made aware of the potential problems the drug can cause. When you give a drug that carries a black box warning, you need to monitor the patient even more closely than usual for possible problems. Medication reconciliation. Medication or drug reconciliation is the practice of comparing the patient's drug orders to all of the drugs that the patient has been taking. By doing so, you can avoid drug errors caused by wrong dosages, duplication of drugs, and leaving out a drug. The nurse compares the list of current drugs to the list of prescribed drugs to check for accuracy. The list includes all over-the-counter drugs, herbal supplements or vitamins, and prescription drugs the patient takes on a daily basis. Teach your patients to carry their most recent drug list with them to all healthcare provider appointments and to update the list as it changes. Protection of healthcare workers. Unsafe clinical practices, such as recapping of syringe needles, can result in needle stick injuries and exposure to blood-borne pathogens. Needle stick injuries expose nurses to serious infectious diseases such as hepatitis B and C and HIV infection. Regulations require hospitals to have a written plan for reducing the risk for needle stick injuries among healthcare workers. Employers are required to provide the safest equipment available regardless of cost. Such equipment includes needleless products and equipment with engineering controls that have built-in safety features to reduce risk. Sharps disposal units must be available in areas where needed if a needle stick injury does not occur. It must be carefully recorded in the agency's needle stick injury documentation system. The exposure control plan selection of safety products and needle stick injury documentation system must be reviewed at least once a year. Safe disposal of drugs is a primary concern for the health and safety of the population. The following tips are used for the safe disposal of prescription drugs. Follow the disposal directions on the drug packaging or insert. Unless directed, do not flush drugs down the toilet because they can pollute the environment. Bring unused or expired drugs to a local drug take-back program. Consult with a pharmacist about drug disposal guidelines.